As an orthopedics PA, you're going to be responsible for the non-op treatment of a lot of distal radius fractures. So in this video, I'm going to go through how I like to treat distal radius fractures so you have a practical guide and evidence-based guide to help maybe guide your own practice. I'm a board-certified orthopedic surgeon. I've been in orthopedics for more than a decade. I took more than 200 trauma calls last year. I treat distal radius fractures. I fix distal radius fractures, but the vast majority are treated non-operatively. I work with a lot of amazing PAs, and a couple of the really spectacular ones I have asked, well, how'd you get so good at this? How'd you get good at orthopedics? And amazingly, a lot of them end up saying things like, well, I was left alone without much supervision, so I just had to figure it out, whether that's in the OR or just being in a practice managing fractures all by themselves. I don't want that to happen to you, so I'm gonna make this video to help guide you so maybe you don't have to go through the growing pains that those guys did. As an overview, what we're gonna go through on this video is number one, some misconceptions about treating these fractures. Number two, the general week by week overview of how I treat these. And then finally, the nitty gritty details, the granular details about how I speak to patients, the type of things we talk about, all the specific restrictions and goals of each level of treatment. So the top three misconceptions. The first misconception is you have to immobilize fractures for 6 weeks of casting. Studies have shown that 6 weeks is just too long. We don't need it. 4 weeks will suffice. And there's even studies to show that 1 to 3 weeks for really stable fractures, the non-displaced, minimally displaced fractures, only need 1 to 3 weeks. So get rid of the 6 week idea. That's too long and you're just causing more stiffness. Misconception number two, you have to immobilize above the elbow. So time and time again in multiple studies, we've shown that above the elbow versus below the elbow really makes no difference in holding these fractures. Ultimately, about 30% of these are going to lose their reduction, whether you do a short arm cast or a long arm cast. And so why torture your patients by mobilizing their elbow? And believe me, if you free up their elbow, they're going to really thank you and they're going to love it. And misconception number three is all patients need physical therapy. And again, the meta-analyses show in multiple papers that for this and a lot of other orthopedic injuries, formal physical therapy doesn't really help in the long run. And there's also the added cost of things like transportation, co-pays, and some physical therapists are just overly aggressive in my opinion. And so they actually cause pain, which causes this whole other cycle of pain and stiffness and fear of moving the joint. So those are the three main misconceptions. Let's go into the quick breakdown, the general overview of how I treat them. So they will start the injury. They usually end up in the ER and placed in a sugar tong splint reduced. And I'll leave them in that reduced sugar tong splint for 1 week, at least 1 week. Weeks 2, 3, and 4, they'll be switched to a short arm cast. At the 4-week mark, the cast is off and I'll put them in a wrist brace with the instruction to wean that as quickly as possible. So weeks 5 and 6 is removing the immobilization period. From week 6 to 12, that's when I allow full motion, strengthening up to 5 pounds, even some driving. And after 12 weeks, patients can do whatever they want. So here are the more fine details of what we go into. So we're not going to talk about all the indications for surgery. That's for another talk. And then especially for the elderly patient population, the 65 and older fragility fracture patient population, that's the main focus of this talk. So these younger injuries, the high-speed motor vehicle accidents, that's sort of a whole nother animal, whole nother type of treatment algorithm. And we can talk about that in a later video. So we're talking about fragility fractures. They go to the ER, they have a fall from standing height, they get reduced, and they're in the sugar tong splint. Now, based on recent studies, you probably shouldn't cast them right away in a short arm cast or a short arm splint and they'll do just the same, but 99% of what you'll see in an emergency room is going to be a sugar tong splint, and that is totally fine. So they come back, I like to bring them back within that first week. So within a day or 2 or 3 of them getting reduced, I'll bring them back. And their main reason is to check the splint. Now in each stage, I'm going to go through the mobilizations, things to think about, the discussions we're going to have, what we're going to look for in the examinations, and the goals and limitations of each step. So in this first step, week 0, you're looking at the splint, and most importantly, can they flex their MCP joints? And they can't do that if the splint extends past this distal palmar crease or the heart line. If they are too long on that side, I'll actually get a cast saw and trim it down to the point where they can flex their MCP joints. Beyond that, you're making sure the splint is not overly tight or there's no obvious splint material rubbing on the skin. And on the physical exam, always check median nerve function and function of their flexors, especially flexors of the thumb. Any of those are indications to go to surgery right away, and make sure you're looking for that early on. As far as the discussion for surgery, again, as a general overview for the 65 and over patient, surgery in the long run doesn't seem to have any data to support that it's going to provide any better function. We do know it makes a wrist straighter, it can make the x-rays look better, but by 12 months, everyone does the same. So the main discussion will revolve around the goals of the patient. And the first one is, number one, if their wrist is significantly displaced, if they have a significant deformity, can they tolerate that? So essentially, I'll say, well, you're going to have a crooked wrist, but other than having a crooked wrist, you'll do about the same as if we do surgery. How do you feel about that? And surprisingly, most people don't mind having a crooked wrist in that age group, especially if it's their non-dominant extremity. So that's the first thing. Do they mind a crooked wrist? And if they really can't live with a crooked wrist, well, then that would be a reason to have surgery. The second thing is, are they extremely active and they want to get back to activity right away? This could be for many reasons, one of which is they play sports, they play pickleball, they do yoga. Some people have a lot of demands in their lives, maybe they're a caretaker for someone else and they just don't want to be in a cast for 4 weeks. Well, that'd be another reason, because one advantage of surgery is that once you immobilize the fracture with the plate, you don't need the casts anymore. That's a general overview of surgical indications. Like I said, this is not a complete review of non-op versus operative indications, but that's a general conversation I'll have with the patients at that week 0 mark. The limitations of this, pretty much not lifting anything. If they have to lift, say, a fork to feed themselves, that's okay. Otherwise, they're staying in the sling, wiggling their fingers, wiggling their hands, and that's it. Let's move on to the next week. So I'll bring them back in 1 week. So now they've been in the sugar tongue splint for 1 whole week. It's at this visit, we'll take down the sugar tongue splint and move them to a short arm cast. Now the key to a short arm cast is that the padding is very minimal. You don't want to overly pad it because you're more likely to lose what reduction you have maintained. So keep the splint padding to a minimal. If you're going to pad, just pad the edges of the cast at the top, around the thumb, and at the bottom. Other than that, leave it minimal. Make sure they can flex all their fingers, especially at their MCP joints. On the exam, the reason I like to take the sugar tongue splints down at a week is, number one, the bones are sticky enough that if you're very quick about it, you're not going to lose a reduction at that moment. And you want to do a good soft tissue exam. A lot of patients in this age group has very fragile skin. You want to make sure there's no open fractures, no skin tears. There's usually the Band-Aid that's still there from the hematoma plaque that needs to be removed. So you do want a thorough exam. And once again, checking median nerve function, checking function and documenting whether their thumb is flexing, the FPL and EPL, making sure that's documented on every visit. Limitations in this stage, once again, you can lift knife or a fork to feed yourself, maybe a pen or a pencil, and that's it. Do allow them to move their hand and their elbow at this point, and most of the time they're just overjoyed to get out of that sugar tongue splint so they can get their elbow back. I like to bring them again back a week after that. So now we are at the 2 week mark. This is in some ways the point of no return when it comes to discussing surgery. But at the 2 week mark, I like to get a set of x-rays, and then we'll keep them in that short arm cast. The exam is going to be the same, making sure the median nerves work and their thumb flexors are working. But since they're in their cast, there's a limited examination you can do. The main discussion is the final opportunity for surgery. And at this point, it's already a bit of a challenge because the bones have started to heal, but it's not too late to go in and correct that deformity if they want to correct it. The limitations at this point are the same as before. Move the hand, move the elbow, nothing more than a knife or a fork. After this point, assuming we're still doing non-operative treatment, I'll bring them back in 2 weeks. So now we're at the 4 week mark after the injury, after the reduction. And now I take everything off. The cast completely comes off. I do like to put them in a removable wrist brace because most people don't feel comfortable going from a cast straight to just having nothing. Most of them want some sort of brace support. You actually don't need it, but I offer to patients because most of them feel more comfortable. But I give them strict instructions to wean that brace as soon as possible. So start by living an hour a day without it, and 2 hours, and 6 hours, and 12 hours. So hopefully by that first week, they're not using any sort of immobilization. What we want to discuss at this point is that the bone is completely healed, or at least 90% healed at 4-week mark, is stable enough to do whatever motion they want to, provided they don't lift anything heavy. Surgery at this point is probably not an option. If there's a highly unusual situation in which you've lost a significant amount of deformity within the last 2 weeks, which is unusual, then you can have the surgery discussion to correct the deformity. But I find the biggest deformity, the biggest loss of reduction is going to happen in the first 2 weeks. After that, the fracture is going to stay where you left it at week 2. And because of that, there's a lot of studies and there's current recommendations that you actually don't need x-rays past about week 3. It won't really make much of a difference in the patient's outcome or any sort of treatment algorithms you might be following. So the goals and limitations. So we're at 4 weeks out. There's no mobilization other than the wrist brace, which you're going to wean. And our instructions are move, move, move. Make a full fist. Move all your fingers. Supinate, pronate. Use your elbows, use your shoulder. Try to get back to doing more normal things, provided you're not lifting anything heavy. Still not weight bearing through that wrist if, say, they're using a walker or a cane. So we'll come back at that point, come back at the 6-week mark. So 2 weeks later, now we are 6 weeks out from the injury. And then by then, hopefully they're not wearing the wrist brace anymore. They have a reasonable motion. And by then they should be non-tender. And if all those are true, they're moving without pain, they're non-tender, even if they're a little weak and stiff. This is when I allow them to start driving again, very short distances, no more than 30 miles per hour. They're not allowed to go high speeds on the interstate at this point, but if they need to go to the grocery store, they need to drive to physical therapy if they choose that, it gives them back some semblance of independence that they have lost over these first 6 weeks of treatment. So the discussion at this point is that the fracture has healed. They can have physical therapy. I'll be clear that if you are comfortable doing the exercises on your own, it doesn't seem to be much of a difference whether you have formal physical therapy or not. But some people like to have the added help, the added professional looking at their wrists, encouraging them, keeping them accountable and moving them. And there's certainly nothing wrong with physical therapy. And like I said before, the problem with physical therapy, it can be very costly depending on your insurance. Copays up to $50 a session. There's also the transportation issue of getting to the physical therapy place. And some physical therapists are just overly aggressive, and I'm not a big fan of that. Week 6 through 12, I would like them to move fully, of course, but also start building strength up to 5 pounds, which is about a half a gallon of milk or juice. Usually I will print out an exercise program. There's many websites that do that. My personal favorite is My Health Alberta. Our neighbors up north has a great website. It has a whole list of all sorts of home physical therapy programs, not just for distal radius, for a slew of other pathologies you might find in the orthopedic practice. I'll bring them back at the 12-week mark. At 12 weeks, I might get another set of x-rays just to verify that everything's completely healed. You want to check the callus formation, which is formed at that point. But at 12 marks, I let people go. By and large, most people are very, very happy. They're back to doing most of their normal activities as far as eating and cooking and driving and doing those things. Most people are generally happy. At this point, some still might have some stiffness. They probably have some weakness, but they're doing most of their daily things without much issue. So at the 12-week mark, they can do whatever they want. They can go back to lifting things, weight bearing through their wrists. They can go back to driving more normally. And then I will usually check one more time at 6 months. If at the 3-month mark they're doing exceedingly well and they just don't want to come to the doctor, I think it's safe to have them follow up as needed at that point. But as a general rule, I like to see them back one more time at the 6-month mark to make sure they've reached all their goals, they don't have any concerns. And in the rare case, we can talk about if they want to correct the deformity with things like correctional osteotomies or even ulnar shortening osteotomies. That is the discussion to be had down the road. So that's how I treat distal radius fractures. I really hope this is helpful. Please let me know in the comments or send me an email if there's anything else you want to talk or any questions you might have. Really appreciate the support by watching this video.